Welcome everyone to our, is this our first meeting of January? I think so. And I'm not going to take any time except to introduce myself to the few people I don't know. I'm Jean Stellman. I'm the president of EPIC. We're happy to see new faces. We're really delighted to have Dr. Ginsberg here, and Eric Heyer, our executive committee member, is going to take over from here.
Yes, it's a real pleasure to have Dr. Ginsberg here. Dr. Ginsberg has a long track record at Columbia. He's been there, 40 years?
35.
35, all right. We'll keep it 35. We'll work on, 40 will be the aspiration. And he's been the Herbert and Florence Irving Professor of Medicine and Director of the Irving Institute for Clinical and Translational Research. So,
Hold it up closer. Just hold it closer.
so he's been the Director of the Irving Institute for Clinical and Translational Research, and has really played a major role in a lot of our lives for those of us who have been very interested in doing clinical outcome studies, and has really done an unbelievable job. He's also, his main interest has been in hyperlipidemia, and particularly treatment for patients who have hyperlipidemia and some of those components of the hyperlipidemia complex that lead to cardiovascular diseases and cardio and cerebrovascular diseases. He's also been honored recently as an outstanding with the Outstanding Investigator Award from NIH, and received $4 million in support over the next 7 years. So he's been director of the Irving Institute for 22 years. He's had NIH funding for at least 40 years, and he's received numerous awards from the American Heart Association and the American Diabetes Association. So it's really a great pleasure to be able to present Dr. Ginsberg, who's going to tell us whether we should have statins in the drinking water. I'm in favor of it personally, but we'll see what you have.
I have this. I'm on.
Oh, you're on.
I'm on. Thank you, Eric. It's a pleasure to be here. I think my at present plan is that about 4 more years I'll join you. People think I've retired because I stepped down from running that institute, but I'm somehow just gone from 80 to 60 hours a week, maybe 20 hours a week over the next 4 years, and I'll end up retired and join you for these luncheons. It's also a pleasure to be here because anytime I can get to do something special at Columbia, it's nice. I wasn't even waitlisted when I applied to the undergraduate program here. And I didn't even bother to apply to the medical school. So I took a circuitous route to get to where I am. It's probably one of the reasons I worked so hard all my life to prove to myself that I belong. And so maybe this is one of those pieces of evidence. Okay, so this is what I live and breathe, and there are a couple of different parts of this presentation. There's a little bit of epidemiology of cardiovascular disease, and then moving on to cholesterol as a major risk factor for cardiovascular disease, and then treatment, focusing on the statins. I'm also going to put some diet issues on the table because it's always fun to bring up what people eat. And there's so much in the news all the time. And if there's a little bit of time at the end, I want to save time for questions. Talk like this from an audience like this always brings up a lot of questions, but there'll be something maybe a little bit extra at the end. I'm still fortunate enough to have some industry-sponsored work that I do, but as you heard, it's I'm employed by the National Institutes of Health. Have been since, as you know, I don't know, well, downtown you actually probably, some of you get salaries. Uptown, you know, we get a card that we swipe when we come in, and they reduce our salaries each day for showing up. So this is an alternative title, but it's an outline of what I'll be speaking about. First, that LDL is bad for you, and I'll get into a slight nuance without any data about, because people seem, if they read any scientific literature about LDL, they hear about sizes and particles. Tell you that lowering LDL is good for you no matter how you do it. That dietary saturated fats and cholesterol in the diet are bad for you because they raise LDL, irrespective of what a lot of magazine covers and even the New York Times and sometimes editorials in Nature will say, and that statins are good for you. So this, let's see, is that it? Oops, that wasn't it. Okay. Is there a pointer attached to this, or is it just up and down?
Oh, the pointer?
Oh, is it the?
Yes.
Which? The little star on top? Oh, yeah, okay. So this is what hopefully you won't look like at an autopsy. This is somebody who probably fell down dead in the street. This is a cross-section of a coronary artery. This is an atherosclerotic plaque filled with cholesterol and with white cells that take the cholesterol out of the artery, but it failed. This is a normal artery always has a lining, a single layer of cells called endothelial cells, and here is a crack in that lining created by the stress of the plaque. And as I tell my patients, if you cut yourself in the back of your hand, you'll bleed, and then you'll stop bleeding because there'll be a rush of cells, including platelets, to form a clot. And when you cut yourself on the inside of an artery, the same thing happens, but that's not good. And if it totally occludes the artery, you have a myocardial infarction or a stroke. Okay. If it happens in your legs, you get acute ischemic event and loss of blood flow to a limb. And this is just a close-up of where this crack occurred. And so this is a pulling together of some data. It's online, but in the US, about almost 100 million people have cardiovascular disease, which includes coronary artery disease, stroke, congestive heart failure, and also peripheral vascular disease. It's the #1 killer of men and women. Almost over 800,000 deaths in 2018, one of every 3 deaths, one every 38 seconds. 720,000 new heart attacks and 335,000 recurrent heart attacks in that year. And it's important to note that of these events, about 20 to 25% of those people die at the moment of that event. They don't get to a hospital for a stent or for bypass surgery. And a significant proportion of those people have not had any treatment because they've never had a symptom. And so they're the people that you may hear about, unfortunately. Somebody knows somebody who just dropped dead. And it's an acute myocardial infarction, and it was the first thing that happened to that person without any warnings. And that raises the issue of prevention and screening and things like cost effectiveness. 1 out of 7.5 people died suddenly, as I've just said. And at the present time, there are about 8 million people in this country alive who've had an event. These numbers are always gigantic, but this is back in 2014. It takes longer to collect these data usually. A lot of money is spent every year and it's loss of productivity as well. And then there are a lot of strokes, new strokes and recurrent strokes each year. So why do people have this happen to them? Well, there are the big guns. There are LDL cholesterol levels, diabetes, hypertension, smoking. These are the two immutables, and age is the strongest risk factor for a cardiovascular event in just about 99% of the population. A few monogenic disorders, maybe with LDLs that are sky high from birth, can cause events even in adolescence, but clearly as we get older, our risk goes up regardless of what the others look like. I put this person up. Bill knows him very well. Daniel Steinberg, who passed away about 4 or 5 years ago now, a little over 90 years of age, and was one of the pioneers of the entire cholesterol, lipid, heart disease prevention field. Just a brilliant man who wrote a book called The Cholesterol Wars. It was a series of articles in the Journal of Lipid Research, but it's online. And he goes back to the 1800s, the early rabbit studies, feeding rabbits bad diets, and moving forward over the decades. Because there is still, it's amazing in this time that there are still cholesterol deniers, as I'll use that term, particularly in parts of Europe and Scandinavia. And it's not just related to statins, where there's always been a lot of controversy. It's just related to the whole idea that cholesterol causes heart disease. So you might be interested in looking that up. The data linking total cholesterol, and more specifically LDL cholesterol and heart disease, is overwhelming. There's hundreds of slides that I could pull out and show. I've tried to stay away from that. But this is an interesting one, looking at a number of areas in the world linking cholesterol levels measured in those areas to heart disease mortality. And there are differences. There's a lot of variability. If you take a cholesterol of 200, which in general would mean an LDL of maybe 120 or 130, for those of you who are familiar with your LDLs. And you can see there are other factors that come into play. And particularly, these are old data, so smoking might vary greatly, as well as other factors that come into play. But in general, if you just did a regression here, you'd see this very striking line. And in fact, if you look at Japan, always it's of interest to me, at least, and another thing I tell my patients, in the 1960s and 70s, the average LDL cholesterol in Japan was about 65 to 70 milligrams per deciliter. They smoked like chimneys. They did eat a lot of fish, but they also had a lot of high blood pressure. They had a moderate amount of diabetes. They had no coronary disease. They had strokes because of the blood pressure. But that LDL of 70 protected their coronary arteries. Okay, so high LDL is bad for you. And so this is a lipoprotein. So cholesterol travels through the blood mainly attached to a fatty acid so it's a cholesterol ester, and triglycerides, the energy molecule. Cholesterol has no energy content, no energy association. It's just a structural molecule in all the cells of the body, and it's a precursor of many hormones. But both of them travel through the blood, the triglyceride and the cholesterol ester, and they're insoluble in water because they're oil. And so Mother Nature gave us this thing called a lipoprotein, a lipid protein complex, with cholesterol and triglyceride in the middle, and a coating of a lipid that's called phospholipids, which is okay looking outward into aqueous plasma or blood, and inward looking at an oil droplet. And there are proteins on lipoproteins that differentiate their function and their meaning in terms of risk for cardiovascular disease, for instance. And this is a protein that's kept me funded for 45 years, called ApoE. It's the protein necessary for a liver to put out a precursor of LDL called very low density lipoprotein, which becomes LDL in the plasma, and it's an important causal risk factor, as is LDL cholesterol, for cardiovascular disease. Now, this is a particle, this cartoon suggests that it's a very uniform family of LDL, but it's a spectrum. There are small particles, there are big particles, most of them are middle-sized particles, and the size depends on other factors that are beyond the talk today, but they're all bad for you. And so here's just one case of a classical instance where the proof of LDL being a problem is obvious. This is a 30-year-old woman. BMI of 24 is the upper limit of normal. Hemoglobin A1C, a measure of glycemia or glucose over several months, is perfectly fine. Total cholesterol, though, of 400. That's probably the 98th percentile, 99th percentile. LDL of 300, again, the 99th percentile in the population. Perfectly normal, super normal triglyceride, and a very healthy HDL cholesterol. Okay. Sometimes we use this non-HDL, which is simply the difference between the total and the HDL, because there is some cholesterol traveling with triglyceride. You don't see it here, so this gives a little bit more information about the total bad cholesterol. This lady has cholesterol lesions on her eyelids. They're called xanthelasma. She has a thick Achilles tendon because there's cholesterol depositing there. Also on the knuckles, there are cholesterol deposits. These are called xanthomas. And she has monogenic familial hypercholesterolemia. LDL is removed from the blood by a protein called the LDL receptor that led to the Nobel Prize for two people from Dallas, Joe Goldstein and Mike Brown. And she only has half the number of receptors because she has one defective gene. If she married someone with the same heterozygous form of familial hypercholesterolemia, 25% of that, each child would have a 25% chance of being homozygous, and that child would be born with an LDL cholesterol from 500 to 1,000, and without some therapy would probably not live past the middle adolescent years because of a heart attack. We have treatments for this lady that are spectacular now. The treatments for a child who has a double loss of function are much less adequate, but are getting better. Okay, so that's LDL. Lowering is good for you no matter how you do it. And this is just one slide. Oops. Okay. So this is, and there'll be a few more slides like this. This is just a meta-analysis, a regression of, in this case, 20 where statins were given to people versus a placebo. And this looks at the difference in LDL between the groups. It's in millimoles, so if you multiply these numbers by 40, this would be a 40 milligram per deciliter difference in LDL in the blood. This one would be about where are we? 2. So it's about an 80 to 100 milligram per deciliter difference. But what you can see is the larger the difference between the treated group and the placebo group, the lower the incidence of heart disease, in heart attack or stroke or death from one of those in these studies. And they line up very nicely. Over here are studies without statins. There are a few diet studies in there. There are studies with non-statin LDL lowering drugs. There's a very heroic study that was done in the 1980s with ileal bypass surgery, which caused LDL lowering. It was in people with that familial hypercholesterolemia before we had statins. And all of those studies can also be lined up in a regression. And if you see, the slopes are about the same. And the point is that however you lower your LDL, you will reduce your risk of having an event in the next 5, 10, 20 years. So if you're eating an average American diet, become a vegetarian, and you are diet sensitive, and not everyone is, that might be as good as taking a statin. Usually not as good, though, but takes you maybe partway there. But the concept is important. Okay, so what about dietary saturated fats and cholesterol? This is sort of one of my favorite areas because I like to be infuriated by junk that comes out in papers and even journals. This is an area where there are just charlatans out there writing books, giving lectures, even being invited to Columbia to give lectures. Weight loss and effects of diet on diseases are two areas that the data are so difficult to obtain in a really purely hard scientific way that it's easy to collect junky data, interpret it, and come out with a book. And so to start this off, a little bit of there's some Emeritus biochemistry people here. Okay, I have to be simple. Fatty acids, I mentioned a fatty acid bound to cholesterol, but fatty acids are also, 3 of them are bound to something called glycerol to make a triglyceride. And whenever we eat fat, we're eating fatty acids, and they are long chains of carbon atoms which can be converted to energy. And there are saturated fatty acids. They only have single bonds between the carbons. And there are some that are as small as 4 carbons, 8 carbons, 10. These are the ones that we talk about mostly with diet, 12, 14, 16, and 18 carbons. And as I'll show you in a moment, the 12, the 14, and 16 are fatty acids that raise LDL cholesterol. There are some that are neutral, and some that maybe even, there are some that are neutral. Then we have unsaturated fatty acids, either monounsaturated, one double bond, and that's the famous one is oleic acid, which is the olive oil, the canola oil, major fatty acid, neutral toward LDL cholesterol. There's linoleic and linolenic, polyunsaturated fatty acids. Maybe they even lower LDL a little bit, but we could call them neutral, and they're found in those, quote, healthy vegetable oils as well. And then there are the omega-3 fatty acids, which I'm not going to show you. Maybe one of them is, the precursor is down here, arachidonic acid, and they may actually have other health benefits. If you like oils to cook with, you have canola, which you can see here is mostly monounsaturated, be oleic acid. It's a little bit of saturated. You get down to peanut oil, so you've gone from about 5% to 20% saturates. Then there are polyunsaturates, the brown bars, a little bit of omega-3 in some of these. Flaxseed has the highest omega-3, making it popular for people who are trying to take omega-3s without eating a lot of fish or taking fish oil per se. And this just looks, these are classical from Anthony Keyes, who worked in the 1950s and looked at food intake from countries around Europe and put together a map of the saturated fatty acids that were taken in versus heart disease deaths, and had this very strong correlation between the two. Again, some noise here in the middle, but overall a strong correlation. These are called ecological studies because you're looking at group data, country data actually. And they're not as strong as we'd all like them to be, because you could probably put down, whoops, sorry. You could probably put down automobiles here or indoor plumbing. You could certainly put down, belt size. There are a lot of things that would correlate probably with saturated fat intake in those countries. You might even put down annual income in those countries. I don't know if they'd all be exactly the same, but in any event, this was strong evidence that we should worry about saturated fat in the diet. And people did studies in a more controlled way over many years, getting the same data. As a percent of energy going from almost no saturated fat in the diet to 30% of your calories as saturated fats. Most Americans eat about probably 10% of their calories as saturated fat. If they're eating 30% of their calories as fat, most of that is mono and polys, and then the saturates. But it can range from about 5% to 15%. So you can be in this range, and if you are, you can see the LDL levels that could be different by about 20 milligrams per deciliter, which might be 20% or 15% of your LDL in terms of an increase from a very low saturated to a higher saturated fat diet. And in very careful metabolic studies, Keyes and Hegsted, who was at Harvard, they locked them in rooms and they fed them exactly what they wanted to feed them for weeks at a time. And they looked at lipids. And they came up with mathematical output from regression analyses. And this would say that this is total serum cholesterol, how many milligrams per deciliter would go up for a change, for every, I think, probably a 1% change in energy from saturated fats. And if it was polyunsaturated, it went down a little bit. And cholesterol in the diet, there were some changes. Those were done again by other groups, Penny Chrysethodin at Penn State. And these are all, and we were involved at Columbia at some of these in a multi-center study. This is very reproducible. So, if you're eating an Atkins diet, the real heavy saturated, low carb, high fat diet, we've all in the business seen patients who've doubled their LDL cholesterol from, let's say, 100 to 200. They were sensitive and they weren't losing weight. If they lose weight at the same time, there's some sort of protection from that, from the saturated fats. But these are valid equations. On the other hand, Ansel didn't avoid, this is back in '61 being claimed, the man will save us all. And then this is, I'm not sure what the date is on, 214, scientists were wrong about saturated fats. They don't cause heart disease at all. Well, we know that Time magazine puts people on the cover all the time that they shouldn't put on the cover. Probably only 1 out of 5 covers was correct. And this is just a book by an ex-colleague of mine who is at Rutgers, was at Columbia, who wrote all about Ansel and his wife's. And he lived to be 100. He lived in southern Italy the last half of his life, I think. Near you, Bill? But despite all of those data, we have so much misleading information, and they come and go. You can't get rid of them. Atkins comes back, even though he's been dead now for 20 plus years, he still comes back. Or there's somebody else comes back. The ketogenic diet, which is what Atkins actually came forward with in about 1956, is now back and flourishing. Coconut oil became this really big hit the last few years. And I just wanted to show you what's in coconut oil. And there is something different. If it's coconut milk, it's not that bad. But coconut oil that people have been using to cook with, because some book came out that said how good it was, 88% saturated fats. And these are the two that are probably the worst for raising LDL cholesterol. This is the 12 and the 14 carbon atom. And as I twice as many books that are out in the last year with the same misleading information. And if you want to talk about calories later, that's fine too. This is a slide that I always find interesting, and why the whole country, and these are old data also, but why the whole country is 25 pounds or 30 pounds heavier than it was 35 years ago when McDonald's or Burger King first came out. So this was the French fries, 200 calories. Now it's 600 calories, you know, a Hershey bar. I mean, it was a great treat when I was a kid to have a 6-ounce Coca-Cola, right? And now you've got this enormous bottles of Coca-Cola. Even popcorn in the movies, of course, the hamburgers, everything's supersized, including most Americans. But we do have things we can eat. This just happens to be fish. If anybody asks me what the best diet is, it's fruits, vegetables, fish, and poultry. And anything, you don't have to go beyond that, okay? I don't think you have to be more specific or defining than that. So let's get back finally to the statins, okay? So the statins were identified by a Japanese scientist in the late 70s, named Endo is his last name, and he was sadly overlooked for the Nobel Prize. Maybe not, didn't identify the LDL receptor as Goldstein and Brown did, but he identified the statins, which have really revolutionized the treatment of cardiovascular disease. He found it in he purified it from a fungus. In those days, and I guess still so, pharmaceutical companies, when people who work for a drug company go out on vacation, they often bring back samples of dirt or plants, weeds and things, and look. Back then it was very, very popular. Now it's probably less so because of a more molecular approach. So these are all of the statins but one that's not on this list, called pitavastatin. The first statin really to come out was called lovastatin, and then we had pravastatin and simvastatin. This was Mevacor, this was Zocor, this was Pravachol, and then Lipitor, the one that dominated the field for many, many years, and then rosuvastatin, Crestor, which came on later, and now a drug, pitavastatin, which is very limited in its use. And they come in a variety of doses, and their doses are linked to increasing LDL lowering. They come in different numbers of milligrams because of the affinity they have for the enzyme they block, a rate-limiting enzyme for cholesterol synthesis. And I always have to tell my patients the number of milligrams has no meaning. It's just a biochemical outcome of the affinity of the drug as an inhibitor of the enzyme. What's important is safety. And so 10 milligrams of simvastatin is actually safer than 80 of simvastatin. They're both very safe, but you know, you're not going to get the bang for the buck. If you go this way, 10, 20, 40, and 80 of these three drugs and 10 of Rasuva are essentially very, very similar in safety. And so it doesn't mean that if I only take 10 of rosuvastatin to get this 40% reduction, I'm safer than if I have to take 80 of lovastatin or 40 of simva, 20 of atorvastatin. Okay. Bottom line is, what are the side effects at each of these doses, or what are the side effects at those efficacies? This, another thing I tell my patients is that when they leave my office after I've suggested or actually convinced them to take a statin, I know they're going to go home, they're going to Google statins, and the first 30 hits will be lawyers. Do we have any lawyers here? No one's admitting. Oh, one, okay. And the lawyers will say things like, have you lost your memory? Did you take a statin? Have you lost your hair? Did you take a statin? Et cetera, et cetera. Can you not feel your feet anymore? Did you take a statin? It's amazing when something is used widely, and there are deniers, there are people who, for whatever reasons, come up with alternative universes. Not completely so. I'm not, I don't want to put myself in a corner here, that these drugs have been so maligned and people are so afraid of them that many, many, many people don't take them, even though they've had events, they've had stents, they've had bypasses. And we have other drugs now, finally, and we have alternative ways of approaching the use of the statins. But this is probably the most investigated, examined medication or class of medications that we've ever had. There are hundreds of thousands of people who've been in clinical trials with a statin versus a placebo, or one statin versus another statin. It's not anybody, it's not because of the sort of wonderful people who run the pharmaceutical industry, beneficence of those people, it's that they're all out there trying to market their drug. And because the FDA demanded evidence of outcomes very early on, not simply LDL lowering. Now you don't actually, you can get approved now with a drug that just lowers LDL. If it's a statin, you still have to go on to show a big trial so that they can get the safety of your drug versus the safety of the others. So this is one of several slides that I'll show you. There are a few people in this room who know this kind of presentation very well. This is looking at, I think, hazard ratios, which means your risk or benefit of something happening. The line in the middle, oh, just lost the pointer. I hope I didn't lose. Nope, okay. The line in the middle says that whether you're on the drug or the placebo, you did equally well. If you're to the left of the line, statins are better than placebo. The right of the line, placebo is better than statin. And there are two sets of data here. It doesn't matter. It's a nuance. So look at either one, and then look at the red box at the bottom, which is adding up all the outcomes. 126,000 individuals in 26 trials make the data, particularly on the left side. And the bottom line is that on average, and this is somewhat normalized, so if you lower your LDL by 40 milligrams per deciliter, that's the number, so if you have an LDL of 150 and you take a statin and it goes down to 110, you'll reduce your risk of having a heart attack, a stroke, or dying of either of those by 25% approximately. You lower it 80, you should be close to a 50% reduction. Okay? And that's true, as I'll show you, irrespective of a whole bunch of backgrounds. So this looks at people whose LDLs on no treatment were terrific. They were under 80. They were about 80 milligram per deciliter when they started the study, the 0.2, the 2 millimole. And then the bottom of that gradation is 3.5. So that's about 140 milligram per deciliter. So if your LDL is great and you lower it by 40 milligrams per deciliter, you'll get a 25% benefit. Of course, if your LDL is great, then your absolute risk may be very low. So if your absolute risk is 2% a year and you lower it by 25%, you get down to 1.6% per year. But if your absolute risk is 5% a year and you lower that by 25%, then you're down a significant amount per year. And over 10 years and 20 years, that really adds up. So there's always absolute versus relative. This is all relative risk. This is a slide just showing that men and women have the same benefit, although women have, in all these studies, fewer events. This, sorry, it's hard to see, but this looks at, I think it's five-year risk in different groups. So this is what I said. If your risk is low, you still get the same relative benefit as if your risk is very high. Then it becomes a choice of, how little risk do I want? This looks at something that's really important, came back, and that is death. Because that is the absolute outcome that you're trying to avoid. Okay? And many of the single studies didn't have enough statistical power to show a benefit, but that red box at the bottom essentially shows that for any type of death, you're about, on a statin with a 40 milligram per deciliter lowering, you're about, it's somewhere around, I think, 15% benefit. And it's mostly due to the cardiac causes. Stroke, maybe a little. Non-vascular causes, nothing. And this is, again, this is where I get the 40 milligram per deciliter lowering, gives you a 25% benefit. It's individual studies and individual people in all those studies with a meta-analysis or regression. This is that slide I showed earlier. It's just twice as many studies and just plotted differently. This is cancer. It's always been an issue. If you lower your cholesterol, you'll put yourself at risk for cancer. Certainly not in statin trials. There is epidemiologic data suggesting that people with lower cholesterol levels or LDL levels, particularly in the last few decades of their lives, have a higher risk of a whole bunch of things. But it's more likely they have lower LDLs because they're sick or because they're depressed or maybe other medications they're taking. If you do a clinical trial looking for placebo versus statin, there's no bad outcome for the statin. There is, however, a slight increased risk for diabetes. Okay? And it's about, over 5 years, about a 10% increased risk. It's not like waking up one morning with full-blown diabetes. It's a creeping kind of thing that can happen. But if you put that against the benefit, the benefit far outweighs the risk. But there are people who are on the verge of getting diabetes because they have what we call metabolic syndrome. They're obese, they have high blood pressure, they have high triglyceride, they have low HDL cholesterol. They're already at higher risk over a 5 or 10 year period. And if they're on statins, they're the ones who are liable to creep over the boundary. But again, if you're taking a statin for 25 years, you started at age 50, now you're 75, and your blood sugar goes from 115 to 125 or 127, and now you call diabetic, but you've prevented yourself from dying over those 25 years, and you have a minimal diabetes that can be controlled either with better diet, with weight loss, or with a single drug that's safe, then that seems to be a reasonable deal. So these are the things, though, that I deal with about at least 1 or 2 patients a month, and I only see patients a half a day a week. That is the common complaints. The most common complaint with statins are muscle aches and pains, myalgias, myositis. Some people say it's their joints. So, if you measure something called creatine kinase, an enzyme that comes out of muscle when it's damaged, and you take 1,000 people with those kinds of complaints, about 5 to 10 of them will have an elevated creatine kinase, CK level, without some confounder like exercise. So now, having said that, maybe one of those 5 or 10 will actually have a really bad disorder called rhabdomyolysis, where not only the CK is elevated, but their muscles are falling apart, and it's spilling out proteins that can collect in the kidney and cause renal damage, and can be fatal if not treated properly. Okay? But it's extremely rare. So 99% of people with these complaints of muscle complaints, we don't know what's going on. Many of them have simply read the package insert or the lawyer's ads and have what I call package insert-itis. But there is something that's real. And I can tell you that the ultimate case that I have is he's a psychiatrist, so I have to say that. So, but he's pretty normal. He's about 40 years of age. I started treating him when he was 12 years of age. He has familial hypercholesterolemia. And he's been on, until recently when he went on the injectable cholesterol-lowering drugs on top of the statin and one other drug, he was on like 5 drugs, because his LDL was somewhere in the mid-300s, and we got him down close to about 120 milligram per deciliter on 4 or 5 drugs. And he's healthy, and he has a couple of kids, and he's lived a good life. And And then about 3 years ago, or 4 years ago, he decided to get in really good shape. And he never had a muscle symptom. He ran about 15 miles a week at a moderate pace. He got himself a personal trainer and did one of those sort of boot camp, like 5-day killer exercise regimens, at the end of which he could not get out of bed. He had brown urine, which meant that these proteins from his muscle were spilling through his kidney. And he had a CK, which the upper limit of normal is about 200. His was about 100,000. He knew enough, being a physician, to get himself to the emergency room. He was treated appropriately. He's actually back on a statin now with a different regimen. He's staying away from personal trainers. But this happened to him. And how did that happen? Anybody who takes enough statin or does enough exercise on a statin could probably get something like that happening. But again, it's an extreme case. And most recently, the companies who make the injectable LDL lowering drugs did these special studies because they wanted to get an indication that they would be the drugs to use if you couldn't tolerate a statin, which is about 20% of people on a statin don't tolerate them. They took those people, defined by their clinician doctors and themselves, and they tried many statins, and they put them in a trial where for 6 weeks they received either a statin or a placebo, and for the other 6 weeks they received either a statin or a placebo, a crossover study, and only 25% of them guessed correctly. At least they claimed that they had pain when they were on the statin and not the placebo. The rest either had no pain or they had pain during both periods. And that's probably a sense that we have, that if 20% of people can't tolerate statins, maybe 5%, maybe even a little less, have something biochemical. So there are a couple of genes that have been linked softly to this, but they are predisposed to having something which is not enough to really wipe out their muscles in the typical case, but it's enough to make them uncomfortable or they can't exercise as much. And the other extreme is people take a statin and the next day they call us up and they say they can't get out of bed. You know, they're paralyzed. Fortunately, I said, we have other drugs. We have the injectable drugs. We have some oral drugs. I get away with once a week statin in many of these people, and then I add something else and we can treat them. So it's not completely psychological or psychosomatic, but in the main, it probably is. Liver disease is not a real entity in general. That is, it was, when the drugs came out, the FDA made everybody get liver function tests all the time. However, every year or so, one of my patients, for some reason, and I see them a few times a year, and I always get liver tests, and they'll come in with liver tests 2 to 3 times normal. Now, maybe they had a viral infection. I can't deal with that, but I know we take them off the medicine, and maybe in a handful, of 1,000 patients that I've followed over the years, maybe 3 or 4 on a retest with a statin bump their liver tests up. So they have something as well, but extremely rare. The memory story, I'm sorry if any of you couldn't remember to give your last lecture because you're on a statin, and that's why you became Emeritus, but there is really no evidence that lowering your cholesterol or taking a statin to lower your cholesterol causes memory problems. In fact, because Alzheimer's disease is a separate disorder, but it interacts with cerebrovascular disease. So if you have the genes for Alzheimer's, whether it's E4 or whether it's another gene or just polygenic in aging, and you have bad circulation, you're going to be that much worse off. And because of that, and because the statins and lowering LDL have great effects on stroke, the drug companies thought they might have a drug class good for cerebral problems. And Eric has studied things like cognitive function over the years in people who've had carotid procedures. Well, so those studies did not work. They didn't show protection in people with mild cognitive disorders or dysfunction in terms of progression over a couple of years. But there certainly was no evidence of a negative impact of statins. And electronic health records, which are confounded because people on statins would be on statins because they had vascular disease more often than not. They actually appear to have less dementia when they get older. So of those three, there may be something in the first two that are very, very, very rare, and the third, I can't say much at all. So, you know, I think I'll stop there with, let me see. Oh, should we put statins in the drinking water? That's all. If we did, we might cause some harm to a few people. And if you take a population at large, there might be, you know, more than a handful. But if you lowered LDL by 30 or 40 milligrams per deciliter for the whole country, you would save hundreds of thousands of heart attacks a year and tens of thousands of deaths per year. So it's, you know, it's public health versus individual health. I'm not a strong proponent, but you know, over the years, I've gone from someone who treated people's LDLs when they were 200 to now telling people in their 40s that when their LDL is 130, which is the average for an American adult, that if they can take a statin and it doesn't bother them, and they have an LDL of 80 to 90, they will have a significantly better chance of not having a cardiovascular event when they're 70, 80. And you know, it's always, well, you're telling me I'll protect myself when I'm 80 years of age. Well, some of you are 80. I'm going to be 75 in July. I don't want something to happen to me 5 to 10 years from now that changes my life. I don't want to become not the person I am now. And you know, if you're 90 and you get chest pain and you get to an emergency room, they don't say you're too old to have a stent put in or bypass surgery. So why wouldn't you take a statin to prevent yourself from ending up in the emergency room? And I think I have just one more slide to tell you about. This is something called lipoprotein A, which is an LDL that has an extra protein on it. That's a fascinating protein called apo(a). And this is a protein, this is a lipoprotein that is a small percentage of the LDL family, but it is a significant risk factor for atherosclerotic cardiovascular disease. It's been ignored for years and years and years because it was very hard to measure, very hard to work with in the laboratory, and there were no drugs for it. And we finally turned the corner. There are drugs being developed that are extremely potent. They have to prove to the world that those drugs that lower LPA 80% will reduce heart attacks. We all think that they will, but nobody measures it. And it's 20% of the population it's a very skewed distribution of the population. 20% of people have very high levels. And doctors just don't order it. No one knows if they have it or not. And it's also genetically regulated at a level of 90%. So you have the same level all the time, your whole life. So it's about $25 to $50 for the test. You get it once and you know where you are. And if you're high, you might want to, there's no particular drug for it now, but you might want to be more aggressive or look at your LDL cholesterol. More importantly, you'd want your children to get it because it's a dominant disorder. This is something that, you know, it's been in the papers a couple of times in the last few years. Bob Harper, the physical guy, the trainer who was on The Biggest Losers, had a cardiac event on the east side. He was actually resuscitated and found to have a high LPA, and that next thing he was on Emirit's show, and then there was a New York Times article. And that's how things happen in this country, right? It's science, nobody reads the science. But everybody should know what their LPA is, at least if not for yourself, for your offspring. So, thank you. Happy to take questions. Yes?
What is the mechanism of general effect?
You know, I was just part of a group that wrote like a 25-page article on muscle symptoms and statins. And we really don't know. It appears to be related to the concentration of the statin that gets into muscle. So maybe the statins are detrimental to muscle function, but in general, they don't reach levels that are high enough to get in. And then there are going to be predispositions. Is it a mitochondrial disorder? That's most likely because muscles are just mitochondrial organs. And if the dysfunction of a muscle that causes you to be weaker or symptomatic on exercise with aches and pains would sound like you're straining the muscle and it's dysfunctional, and that sounds like it's oxidative phosphorylation or muscle metabolism. But there are some very, very rare mitochondrial gene disorders that show up in the very, very rare person who has this super high CK just from a regular statin dose. But again, these are like 1 in millions of people. So I can't give a better answer than that.
But you don't know how
You have a microphone.
you don't know how statins affect either mitochondria or whatever. I'm asking, whatever the proximal cause is, what is the mechanism by which the statins are acting on oxidative phosphorylation or whatever?
No, that just hasn't. There haven't been good studies. It's, they're not easy studies to do. The problem is if you do things in vitro or ex vivo, and you use concentrations that are appropriate, you don't see anything. You can always make a cell do good or bad things with enough of any drug. And when you look at the concentrations, they might be 10 to 50 times higher than you'd ever achieve at the tissue level. So what is it? For instance, there's a whole scientific literature on what are called the pleiotropic effects of statins, that it's not LDL lowering, it's all these other wonderful things they do. And it all comes from cultured cell studies where they throw a ton of a statin on and they see something. Now, there probably are beneficial effects at the cell level due to less cholesterol in the blood and less cholesterol getting into those cells. But those, the slide I showed that LDL lowering with a statin or LDL lowering with any other mechanism have the same efficacy suggests there's nothing special about the statins other than LDL lowering. But I can't answer your question about the mitochondria.
Supposedly, in Africa, there used to be a tribe living as a hunter and gatherer tribe, living primarily on hippopotamus meat, which is very rich in cholesterol. And their LDH supposedly was all over 300. And none of them ever had a heart attack. So, transforming this to our world, we are not hunters and gatherers, but most people who have high LDH in our part of the world have other risk factors, hypertension, obesity, whatnot. What else? Do we have any study in the Western countries, where you study people who have high LDH but have no other risk factors? And what does that high HDL do? Not HDL, LDL, of course, do.
So, two answers to that question. First of all, and I can't give you the number, but my bet would be that the average survival of that tribe, age of death, was in their 50s, right? They were eaten or trampled by hippos. They had infections. You know, the same thing with, actually the original, little sidebar, the original data that said that fish oils are good for you comes from the Eskimos and the Inuits. They would eat this blubber all the time, and they wouldn't have heart disease. Now, that was another story, though. They died of tuberculosis or accidental death. So it's, but I think the example I started with, familial hypercholesterolemia, it's not so true now because of more prevalent obesity and its complications. But when I started out, the typical patient with FH was thin and had great blood pressure, great blood sugar. Why? Because they knew everybody in their family had died very early. There were no drugs, and they knew their LDL was sky high. and yet they still were getting atherosclerosis. So those are the kinds of, and then, of course, for what it's worth, with the extrapolation in mind, you make animal models. Okay, mice don't get atherosclerosis. But if you knock out their LDL receptors and you put them on an American diet, they get, in 4 months, they get horrible atherosclerosis. So I think there are, but the human example, and at the other extreme, we have individuals who have very low LDL due to a loss of function of a gene. And they are probably 40 to 50% less likely to have an event over their lifetimes. So, and that's against people who have the same other risk factors. So.
But is there such a study of people like us with no risk factors? Age is, of course, a risk factor. I have high cholesterol, but no other risk factor. But age is a risk factor. All right. So, but is, of such people, what happens?
So there are studies of octogenarians, centenarians, excuse me, actually, and the genes that pop up there have been HDL genes, but now HDL has fallen into a bit of disrepair that people with very high HDLs may not be protected. I think in epidemiologic studies, unlike total cholesterol, where, and I think Bill could talk about this, there's been a J-shaped curve. The people with high total cholesterols have high events, it comes down, and then at the bottom there's a rise again if you're too low. And that's thought to be these confounders of other diseases. If you look at LDL in gigantic populations, so it's a mixture, you just have this straight line. The higher the LDL, the more risk there is. Sure, I have patients who have familial hypercholesterolemia who've never had an event. They have LDLs, they never got treated, for whatever reason. LDLs are 200, 220, and they've never, nothing is 100%. And be nice, people have tried to study those individuals, see what protects them. We now have what's called polygenic risk scores. They're identifying genes that have effects on outcomes, not even knowing what those genes do. So there's a whole menu of places to, things to look at that may be protective against the high LDL. But in the general population, you're going to fall by the wayside. Yes?
You focused on the intake of fatty acids as a risk factor. What is the current thinking on salt and its role?
That is another area that becomes extremely, has always been controversial. And the people argue about the guidelines of how much salt you should take in, because some people are for very strict guidelines, and there are other people worried about the construction worker who's out there in 100-degree heat with a 1 gram sodium diet, having hypotension and things like that. I think in general, if you have high blood pressure, if you're, let me get it straight, I don't want to make an error here. Yeah, African Americans are less sensitive than Caucasians to salt. But in general, if you have high blood pressure and you drop the salt in your diet, or you take it, you'll drop your blood pressure. Again, there are a lot of the data at the low end come from places like these natives in the middle of the Amazon who had no salt in their diet and had systolic blood pressures of 80 or 90, not having strokes or heart attacks. But again, life expectancy was very low. So I think in general, most people would accept the fact that if in general population, higher salt leads to somewhat higher blood pressure. How important is less clear than we thought.
Can you mention C-reactive proteins and whether they're thought to be important in this?
Sure. So C-reactive protein is made in the liver, and it's in response to signaling from what we call, well, there are proteins called interleukins, for instance, or cytokines in general that come out of different tissues, particularly the adipose tissue. And they get to the liver and they turn on a whole bunch of things, including C-reactive protein. And C-reactive protein gained prominence because it was easier to measure than the others, like TNF-alpha and IL-6 in particular. And because they were championed by a very aggressive Harvard cardiologist, Paul Ritke, they became a big item. They are not the protein is not causal for atherosclerosis. That's been clearly proven. It's a marker of insulin resistance or inflammation. That's not trivial. And it comes back maybe to the question. There are people who are much more pro-inflammatory than other people on a genetic basis. C-reactive protein can be a marker for that. People with type 2 diabetes who have insulin resistance have high C-reactive proteins and high cytokine levels. So if you have very low predisposition to inflammation and you have a high LDL, that won't cause the complexity of that plaque, which will probably be in favor of the plaque never rupturing and never causing a heart attack. And if you are pro-inflammatory, maybe your body, and that may have been a good survival thing 150,000 years ago, because the artery wall was not seeing LDL cholesterol, it was seeing bacteria. And if you responded very aggressively to bacteria in your artery wall, you survived, potentially. Much more likely to survive than if you didn't. Now, of course, in modern era, things that were good back then are not so good anymore. So measuring C-reactive protein has never been something that I've done because I can tell who's going to have a higher level. Certainly, if you've had an event, there's no reason to measure it. You've already had an event and survived, and we're going to treat you very aggressively. If I took a different bent toward treatment algorithms for my patients, and I said, I'm going to lower your LDL to X if you have a normal CRP, and I'm going to lower you to X squared if you have a high CRP, that might be, I might approach the patient differently. But I treat everybody aggressively. So the statins lower C-reactive protein very dramatically. It's not been proven that that adds anything to the LDL lowering, or it's simply a concomitant of the LDL lowering. And there have been attempts at making mouse models that overexpressed or didn't have C-reactive protein, and that didn't matter. And something called Mendelian randomization, where you look at variations in genes that affect something like C-reactive protein. You don't see on cardiovascular disease if a gene raises C-reactive protein from birth versus it lowers. That's hard evidence against causal relationship. Alan.
Thank you very much, Henry. So you're a missionary on a cause. You know what happens to some missionaries, so I hope you'll be very careful.
I get my head on a spike.
Because you know, to me, the big issue is you're advising millions of people to take a serious medication when they feel healthy. They feel healthy. And if it weren't for their blood tests, they wouldn't even know they have this issue. So that's, maybe you're doing the right thing. You showed us about 5 or 6, or maybe, I don't know how many statins there are nowadays. Are there any real important therapeutic differences, or is it all marketing?
So the differences are in the potency. And again, you know, I always tell relatives that calls me up and says, my back hurts, can you recommend a doctor? And I say, what do you want done, right? Do you want to have surgery? I can send you to an orthopedist at the spine center, or a neurosurgeon, or I can send, do you want physical therapy? I'll send you to a neurologist first, then they'll send you to a physical therapist. If you come to me, you know, it's very likely you're going to get your LDL lowered as much as I can without causing you a problem. And because all the data says lower is better. So in that sense, you know, AHA, ACC, all the guideline commissions have divided the statins into high intensity, moderate intensity. They don't even bother with low intensity. And the difference in statins, you know, is, if I put you on a statin at a low dose and you drop your LDL 35%, I put you on a dose that's double that twice. So instead of 20, you're on 80, or instead of 10, you're on 40. And you go from 35% reduction to a 45 or 50% reduction. Once I convince you that the number of milligrams doesn't matter, and it's a very modest differential in LDL, why would I not lower you 50% instead of 35% once you're taking that step? Because the profiles are just about the same at the different doses. There's a little bit more of slight elevations of liver tests with 80 of atorvastatin. The risk of myositis, which I say it's hard to gauge. And getting back to the muscles, there were studies when the companies were developing some of these drugs. If the highest dose you see up there is 80 or 40, some of those companies went to 160 or 320, and they caused a lot of real muscle pain with CK elevations. So it's real if you overdose the muscle with the statin. But at the doses we give, you know, with no CK elevation, it's not clear what we're dealing with. So, yeah, I'm a missionary. You know, you saw the AHA data up there. This is the number one cause of death and disability in the country. And we have a drug that I've worked with for 40 years that I started out very cautiously, and I became less cautious and more familiar and more believing because of all the data. I think you can't avoid looking at them and say, these are great drugs, and I should use them. And lower is better within the context of what the absolute risk is of somebody. You know, I get a 20-year-old who has FH, and their LDL is 250. And I'll say to them, if I have somebody next to you who looks just like you, and every other characteristic is the same, and their LDL is 100, you have about 4 times the risk of having a heart attack in the next 10 years compared to the other person. But their risk is just about 0, and your risk is close to 0. So do you want to wait till you're 30, or do you want to wait till you're 40 to start lowering your LDL? By that time, you're going to have a lot of cholesterol in there, and now we're talking about stabilizing it or trying to reverse it. Why don't we do something now? You know, your father died or your mother died when they were 45 or 50 of a heart attack. Why would you wait? I gave an example of a woman. You run into problems with pregnancy, of course, but in general, somebody who's very high, you start early, you get lifetime benefit instead of, you don't think of 5 or 10 years. So I think those are all the things that come into play.
What are those pregnancy risks?
There are probably millions of women who've become pregnant on statins because they didn't know that they were getting pregnant, and nothing's happened as far as we can tell. But like any drug, you don't want a woman who's trying to conceive and who does conceive and has an embryo to be on any drug. So, you know, when I get a young woman, I probably am totally politically incorrect. And if you know, and I'll ask them, you know, are they planning to have children? How many children? I get patients who plan to have 12 children. And, you know, if they're going to have 12 children in 14, 15 years, an LDL of 250, and I never get to treat them, that's not a good thing. I give them advice, which is, again, probably politically incorrect, but I'm giving what I think is the best advice. I have one back there.
Yes, basic question about nutrition. You said vegetables, fish, and chicken are the best. Yes, but what is the best to cook them with except for water or wine?
We recommend wine.
Okay, so, you know, there are a couple of things. If you're overweight, you don't use, then try not to use any oils, right? Use an air cooker, or use, spread something on the pan if you're not afraid of chemicals. Because you could take a piece of fish and triple the calories by cooking it in. But if you're going to use, then cook in mono or polyunsaturated oils. That's all. You know, not Crisco, which we still send out to like the reservations. And somebody, yes, over here first.
There's a rumor that we women are catching up with you men at risk of heart disease. Is it even true? And if so, how is it reflected in the risk factors?
So women have this protection in general until the menopause, and then they rapidly close that gap. And when you're looking at people over 75, probably more women have heart attacks each year than men. Men at the highest risk are all gone. Right? It's called survivorship. But women and diabetes. Sorry. I don't want any information. Oh, Siri heard me say woman. So she gave me a definition of a woman. I'm trying to shut. Oh, God. All right, I'm going to have to just leave this and hope nothing else happens. Women who have diabetes, almost even early but premenopausal, are almost at high risk as men. Their difference from women without diabetes is greater. That's where they're catching up. Women with familial hypercholesterolemia don't seem to have the protection that other women have. So there are a few things that do that. I think the one in the back. And then I can only take, if I don't get back uptown, I'm going to probably lose a grant. So.
If there were to be a community that wanted statins in its drinking water, how would you manage the logistics? Is it obvious what statins supply? Is it obvious how much to put in the water? And roughly, is it expensive or is it?
Sure. Obvious questions. Well, people only drink bottled water, so if you put it into the supply, I don't know. It's sort of a facetious comment I made, not you. But there are statins in England and maybe in some of the other European countries. The statins are over the counter. And typically you get the healthiest people buying over the counter drugs because they've read it's good for them. So, you know, it's a matter of dosing also. For instance, the over-the-counter statins will be limited to lower doses where they're available in other countries. And there have been attempts to make generic statins over-the-counter here already. And there's something called the polypill, a statin, an aspirin, and an ACE inhibitor, which is an antihypertensive, anti-cardiac ischemia drug. And there have been some studies showing that you can make those pills and sell them, you know, give them out for 5 cents a pill, and you reduce cardiovascular disease in poor countries. So those things are coming, but I don't think we put it in the water.
Well, I really want to thank you for taking the time to come up downtown and talk to us, and really appreciate it.